Today, we're starting our journey into the world of EKGs, or electrocardiograms. This topic is essential not only for the CCMA exam, but also for your hands-on work in clinical practice. EKGs are a vital diagnostic tool that record the electrical activity of the heart and help detect abnormalities such as arrhythmias, heart attacks, and more. In this lesson, we'll break down what EKGs are, why they're used, and how to understand the basic components of an EKG strip. We'll also go over proper lead placement, safety precautions, and how to assist during an EKG procedure. So get ready. This is one of the most exciting and high-impact areas of patient care you'll learn about as a medical assistant. Let's take a moment to review the basic anatomy of the heart. The heart is a two-sided, hollow organ that's roughly the size of your closed fist. It's small but mighty, working non-stop to pump blood throughout your body. An important detail to remember is its location. The heart sits in the thoracic cavity, nestled between the lungs, and slightly to the left of the sternum. That's your breastbone. Understanding the position of the heart is crucial, especially when performing procedures like CPR, taking vital signs, or placing EKG leads. Keep this foundational knowledge in mind as we move forward through the cardiovascular system. The heart wall is made up of 3 layers, each with its own unique function and structure. First, the pericardium is the outermost layer. It's a double-layered sac that surrounds and protects the heart. It also contains lubricating fluid in the pericardial cavity, which helps reduce friction as the heart beats, preventing tissue damage. Next, the myocardium is the middle and thickest layer. This is the muscular layer responsible for the powerful contractions that pump blood throughout the body. It's the main engine of the heart's pumping action. And finally, the endocardium is the innermost layer. It's made up of smooth cells that line the inside of the heart chambers and the blood vessels. This smooth surface helps blood flow easily and prevents clotting or resistance inside the heart. Each layer plays a critical role in keeping the heart protected, functional, and efficient. The heart is divided into 4 chambers, and understanding them is key for any medical assistant. There are 2 atria at the top, the right atrium and the left atrium. These are the receiving chambers, meaning they receive blood that's coming into the heart. The right atrium receives deoxygenated blood from the body, and the left atrium receives oxygenated blood from the lungs. Then there are the 2 ventricles at the bottom, the right and left ventricles. These are the pumping chambers. The right ventricle pumps blood to the lungs to pick up oxygen, while the left ventricle pumps oxygen-rich blood out to the rest of the body. Separating the right and left sides of the heart is the septum, a muscular wall that keeps oxygenated and deoxygenated blood from mixing. The blood always flows into the atria first, then moves down to the ventricles before it's pumped out of the heart. So remember, atria receive, ventricles pump. Your heart has 4 VIP gates, valves, and their whole job is to make sure blood only goes in one direction, no backtracking allowed. First, we've got the atrioventricular valves. Think of these as the gatekeepers between the upstairs lounges, the atria, and the downstairs dance floors, the ventricles. On the right side, we've got the tricuspid valve, guarding the door from the right atrium to the right ventricle. On the left side, it's the bicuspid valve, also called the mitral valve, controlling entry from the left atrium to the left ventricle. Then we've got the semilunar valves. These are the exit doors, making sure blood leaves the heart like it's leaving a packed concert, one way only. The pulmonary valve lets blood out from the right ventricle into the pulmonary artery so it can head to the lungs for fresh oxygen. The aortic valve is the big boss, sending oxygen-loaded blood from the left ventricle into the aorta, ready to travel all over your body. All 4 valves work together like the world's most organized security team, opening and closing at just the right time so the heart's blood flow stays smooth, steady, and drama-free. Your heart isn't just a muscle. It's basically an electric-powered dance floor with its own built-in DJ keeping the beat. That DJ is the electrical conduction system, and its whole job is to control 2 things: heart rate, how fast the music's playing, beats per minute, heart rhythm, making sure all 4 chambers are dancing in sync instead of stepping on each other's toes. The party starts in the sinoatrial node, or SA node, hanging out in the right atrium. This is the heart's natural pacemaker, the one dropping the beat. It sends an electrical signal through the atria, telling them to contract and push blood down. Then, the signal cruises over to the atrioventricular node, AV node, which acts like a bouncer holding the crowd for just a second so the ventricles have time to fill up. From there, it speeds down the bundle of his, yes, that's really its name, not a 90s boy band, splits into the right and left bundle branches, and finally zips through the ventricles. This makes them contract in perfect timing. When all of this happens smoothly, we call it sinus rhythm, a healthy, steady beat between 60 and 100 BPM when you're resting. Each cycle equals 1 heartbeat. But if the DJ starts glitching, the rhythm gets messy, and that's when irregular beats or heart problems can happen. And trust me, knowing this system is key to catching those problems before they turn into an emergency. Meet the heart's hype man, the sinoatrial node, or SA node, chilling in the right atrium. This little cluster of specialized cells is your heart's natural pacemaker, kicking off every single beat. When the SAW node fires, it's like hitting the play button. An electrical signal rushes through the atria, making them contract and push blood down into the ventricles. Next stop, the atrioventricular node, or AV node, the chill bouncer of the heart. It holds the signal for just a split second, letting the ventricles fill completely before they contract. After that quick pause, the signal races down the bundle of his, yep, still not a boy band, splits into the right and left bundle branches, and finally sprints into the Purkinje fibers. These fibers act like a lightning delivery service, zapping the impulse all through the ventricles so they squeeze and send blood flying to your lungs and the rest of your body. The SAW node is ridiculously reliable. It automatically keeps the beat, adjusting your heart rate whether you're chilling on the couch or running late to class. This built-in electrical system is what keeps your heart's rhythm coordinated and your blood moving like clockwork. Every heartbeat is like the heart's own workout routine, called the cardiac cycle, and it's got 2 main moves, systole and diastole. First up is systole, the power move. This is the contraction phase when the heart flexes hard to pump blood out. The atria kick things off with a small squeeze, then the ventricles bring the big push, sending blood to the lungs and the rest of your body. Then comes diastole, the chill move. This is the relaxation phase when the heart takes a quick breather and fills back up with blood, getting ready for the next round. Here's the crazy part. This whole contract and relax routine only takes about 0.8 seconds. Less than a full second. And your heart is doing it non-stop, all day, every day. Knowing this rhythm isn't just trivia, it's key for reading EKGs, checking patient vitals, and spotting when something's off. Because when the beat's out of sync, the whole show is in trouble. Okay, here's the heart's little performance on stage, the EKG cycle. First up, the P wave. This is your atria getting the party started. They're depolarizing, which is just a fancy way of saying they're squeezing to push blood down into the ventricles. Next, we've got the QRS complex, the big spike in the show. This is when the ventricles are firing off and contracting to send blood out to your body and lungs. The atria are actually relaxing here too, but they're shy, so it's hidden behind the spike. And last, the T wave, the cool down moment. This is your ventricles repolarizing, or basically taking a deep breath before the next beat. When you understand these waves, you can read an EKG like you're reading your favorite gossip blog, spotting all the drama happening with the heart. When it comes to doing an EKG, your equipment is the VIP pass to getting accurate results. Mess this up, and you might as well be guessing. Most of the time, you'll be using a standard 12-lead EKG machine. Here's the twist. Even though it's called a 12-lead, you only use 10 electrodes. They go on the arms, legs, and chest, but the magic is that those 10 little stickers give us 12 different camera angles of the heart's electrical activity. That's how we get the full picture. Sometimes you'll see 3 lead monitors. Those are more like quick security cameras, used for basic or continuous monitoring. Then there are single-channel machines, which record 1 lead at a time, kind of like watching a movie 1 frame at a time. They're mostly old school or used for special situations. Now, electrodes. These are the small sticky pads you put on the patient's skin. The gel inside helps transmit the heart's electrical signals to the machine. But they only work well if you do good skin prep, clean, dry, and sometimes shave the area if needed. For a standard 12 lead, here's the layout. 1 electrode on each arm, 1 on each leg, and 6 across the chest labeled V1 through V6. Bottom line, placement matters. One wrong sticker and you could get a reading that makes the provider think your patient's having a heart attack when they're actually fine. So accuracy isn't just important, it's life-saving. Before performing an electrocardiograph, medical assistants must take a moment to clearly explain the procedure to the patient. Let them know what the test involves, placing electrodes on the chest, arms, and legs to record the heart's electrical activity, and reassure them that it's completely painless and non-invasive. It's also essential to verify that you have the patient's informed consent before proceeding. This means the patient understands what's being done, why it's necessary, and agrees to move forward with the procedure. Communicating clearly not only builds trust but ensures compliance with legal and ethical standards. Before an EKG can be performed, it's important that the patient is properly prepared to ensure accurate and reliable results. Medical assistants play a key role in this step. Begin by asking the patient to remove any jewelry, watches, or metal body piercings that might interfere with the electrical signal. Next, make sure they are wearing loose-fitting clothing or offer a gown if needed. Tight clothes can make electrode placement more difficult. Help the patient onto the table if assistance is needed, and always maintain patient privacy and comfort throughout the process. If the patient has hair on the areas where electrodes will be placed, you may need to shave the site and clean it with alcohol to ensure good contact between the skin and the electrode. These simple but important steps help improve the quality of the reading and make the experience more comfortable for the patient. Electrocardiography, aka the EKG or ECG, is basically your heart's personal photo shoot, but instead of pictures, we're recording its electrical vibes. Here's how it works. Every time your heart beats, it sends out tiny electrical signals. We stick electrodes on the skin to pick up those signals, and the EKG machine turns them into waveforms on special grid paper, kind of like a heart's handwriting. The best part? It's non-invasive, painless, and super quick. And those little squiggly lines? They can tell us a lot: heart rate, rhythm, and even if something serious is going on, like arrhythmias or a heart attack. As a medical assistant, you're the MVP in this process. You're the one prepping the patient, placing those electrodes in just the right spots, and making sure the recording is crystal clear. Because if the setup is off, the results could send the provider on a wild goose chase. Electrocardiography is basically like turning your heart's electrical activity into a squiggly line story we can actually read. Every time your heart beats, it sends out tiny electrical signals. We place electrodes on your skin to pick up those signals and send them to the EKG machine. The machine then draws them out as an EKG tracing, a graphic pattern that shows the heart's rhythm, rate, and even the strength of its electrical activity. By reading these lines, healthcare providers can spot things like irregular rhythms, an enlarged heart, or signs that you've had, or are having, a heart attack. It's quick, painless, and one of the most widely used tools in heart care. Basically, it's the heart's tell-all diary, and we just know how to read it. The electrocardiograph is the machine used to record the heart's electrical activity. As the heart beats, it generates electrical impulses that travel through the body. These impulses can be detected on the surface of the skin using electrodes. The electrocardiograph then measures, amplifies, and records those signals. The result is the familiar EKG waveform printed on grid paper or displayed digitally. Each combination of electrodes provides a different lead, or a different view of the heart's electrical activity. For example, lead 2 offers one angle of the heart, while lead V1 gives another. These multiple leads help providers get a comprehensive picture of how the heart is functioning, and can help detect problems like arrhythmias, heart enlargement, or ischemia. First, EKGs are often a routine part of a physical exam, especially for patients with a history of heart issues or risk factors like hypertension or diabetes. They're also crucial in diagnosing a myocardial infarction, or heart attack, by revealing changes in the heart's electrical activity that indicate injury or damage. Next, EKGs help detect cardiac arrhythmias, which are irregular heart rhythms that can be dangerous if left untreated. They can also show signs of heart enlargement, known as cardiomegaly, which may suggest underlying structural problems. EKGs are used to monitor the effects of certain medications, such as digoxin or antiarrhythmics, to ensure the drugs aren't causing harmful changes in heart rhythm. Lastly, they can help detect electrolyte imbalances, like high potassium or low calcium levels, which affect how the heart beats. So in short, EKGs give us a lot of critical information about what's happening inside the heart, and they're one of the fastest tools to help spot potentially life-threatening issues. Let's walk through the proper steps and considerations when performing a 12-lead EKG. First and foremost, patient skin preparation is critical. Patients should avoid applying any substances to their skin before the test. This includes lotions, powders, oils, and ointments, as they can interfere with electrode adhesion and signal quality. Before placing electrodes, use alcohol wipes to clean the skin, and if needed, scrub the area a bit to reduce skin oils and improve conductivity. For patients with body hair, you may need to shave small patches to ensure good electrode contact. Now let's talk placement. The limb leads should be placed on the fleshy parts of the arms and legs, and they must be symmetrical, meaning, if one lead is on the upper arm, the other should be too. This consistency helps reduce artifacts and produce an accurate reading. In cases of amputation, adjustments are needed. If the lower leg is amputated, place the leg electrodes on each side of the lower abdomen. If the lower arm is amputated, place the electrodes on the upper arms. Lastly, remember that a standard 12-lead EKG uses 6 chest, precordial leads, placed on the chest in specific locations. 4 limb leads, placed on the arms and legs. That gives us a total of 10 electrodes to generate 12 leads on the EKG tracing. Don't worry, we'll cover exact placement of the chest leads shortly. Now let's break down one of the most important terms in EKGs, leads. In an EKG, each lead gives us a unique view of the heart's electrical activity from a different angle. Just like how a camera captures different angles of a scene, each lead captures a different perspective of the heart. When combined, these views give us a full picture of how the heart is functioning electrically. Leads don't refer to the sticky pads, we call those electrodes. Instead, leads are the views generated by the electrodes once they're connected to the EKG machine through wires. The pattern and placement of these electrodes determine what kind of lead is being created. There are 2 main categories of leads. Limb leads, which monitor the electrical activity using electrodes placed on the arms and legs. Precordial leads, which monitor activity using the electrodes placed across specific locations on the chest. Understanding which lead gives what view of the heart helps healthcare providers pinpoint exact locations of abnormalities, like where a heart attack is occurring, or which part of the heart has electrical conduction problems. We'll soon go over the exact positions of these leads, but for now, just remember, limb leads equals arms and legs, and precordial leads equals chest. Let's zoom in on the limb leads. They're like the front row seats of the 12-lead EKG. We place 4 electrodes on the limbs. RA, right arm LA, left arm RL, right leg LL, left leg. Here's the plot twist. The right leg electrode, RL, doesn't actually record anything. Nope, it's just there to act as a ground, kind of like the heart's tripod stabilizer. It keeps out unwanted electrical noise so we get a clean, steady tracing. The real action comes from RA, LA, and LL. These 3 make 2 different kinds of leads. Standard bipolar leads. These compare the electrical activity between 2 limbs, leads I, 2, and 3. Augmented unipolar leads. These measure the activity at one limb compared to a reference point made from the other 2, AVR, AVL, AVF. Put them together, and you get 6 limb leads that show the heart's electrical activity from the frontal plane. So remember, 4 stickers on the limbs, but only 3 actually do the work, and they give us 6 different views of the heart. That's EKG efficiency at its finest. Now let's talk about the standard leads, the OG3 leads you'll see on a routine EKG. They're called bipolar leads because they measure the electrical activity between 2 different electrodes, like checking the voltage between 2 points. These 3 make up Einthoven's triangle, a classic EKG concept you'll see in every textbook. Picture a triangle drawn across the patient's chest with each side representing one lead. Lead I runs from the right arm to the left arm, plus. Lead 2 goes from the right arm down to the left leg, plus. This one's the superstar because it gives one of the clearest, easiest to read heart rhythm views. Lead 3 connects the left arm to the left leg, plus. These leads give us a frontal plane view. Basically, you're looking straight at the electrical activity of the heart like it's a front-facing selfie. Once you understand these 3 standard leads, interpreting EKG waveforms becomes way easier, because you'll know exactly where each camera angle is coming from. Now let's zoom in on a really important foundational concept in EKG interpretation, Einthoven's triangle. This triangle is created by connecting the 3 limb leads, lead I, lead 2, and lead 3, which form the sides of an imaginary equilateral triangle around the heart. The heart is roughly at the center of this triangle. This concept was developed by Willem Einthoven, the inventor of the EKG back in 1901. He laid the groundwork for modern electrocardiography with this model. Einthoven's triangle is more than just a shape. It helps us determine the electrical axis of the heart. That axis represents the average direction that electricity moves during ventricular depolarization, which is when the heart's ventricles contract. Understanding the axis can give clues about certain heart conditions, like left or right axis deviation, which can point to hypertrophy, conduction blocks, or previous heart attacks. So, when you hear Einthoven's triangle, think of it as the map that helps us understand how electricity moves through the heart based on the standard limb leads. Now that we've nailed the standard limb leads, let's meet their cousins, the augmented leads. These are called unipolar leads because instead of comparing 2 electrodes like the bipolars do, each one is focused on a single electrode, like zooming in with a camera on just one spot. There are 3 players in this crew. AVR looks at the right arm. AVL looks at the left arm. AVF looks at the left leg, or foot. Here's how they work. Each one takes its view from that limb's electrode, then compares it to a reference point made by averaging the signals from the other 2 limb electrodes. Think of it like pointing your camera at one friend while the other 2 stand in the background for context. These leads still look at the frontal plane, the front-facing view of the heart, but from totally different angles than the standard leads. When you combine the 3 standard leads, I, 2, 3, with these 3 augmented leads, AVR, AVL, AVF, you've now got 6 different frontal plane views of the heart. More angles equals more details, and that's how we catch sneaky abnormalities in specific areas. Let's go a little deeper into why these are called augmented leads. The reason these leads are labeled with avenue, like AVR, AVL, and AVF, is because they record very small electrical signals. The electrical impulses from these unipolar leads are so faint that if we viewed them on the EKG without any help, they'd be too small to interpret accurately. That's where the magic of the ECG machine comes in. It automatically augments, or increases, the signal strength so that the waveforms appear full-sized and readable on the printout. This process is what makes these leads augmented. So when you see avenue, just remember it stands for augmented voltage. It's the machine's way of saying, hey, this signal's a little weak, so let me boost it for you. These leads still provide important views of the heart, especially when detecting abnormalities like lateral or inferior wall issues. So even though they're quiet, they still speak loud when it counts. Now we're shifting from the limb leads to the precordial leads, which are also known as the chest leads. There are 6 precordial leads, V1 through V6, and just like the augmented leads, these are unipolar, meaning each one monitors the electrical activity from one electrode. However, instead of being placed on the arms or legs, these electrodes are placed directly on the chest, in specific positions over the intercostal spaces. Each precordial lead gives a unique view of the horizontal plane of the heart, basically, a cross-section view from the front of the chest. Each lead records the electrical activity between a specific chest site and a reference point inside the center of the heart, formed by the average of the limb electrodes. Here's a quick overview of where they go. V1 and V2. On either side of the sternum. Fourth intercostal space. V3 to V6. Continue along the rib cage, following specific anatomical landmarks like the midclavicular and mid-axillary lines. We'll break each one down in the next slides, but just know that the chest leads are critical for diagnosing conditions like anterior wall MIS, bundle branch blocks, and more. They give us a front row seat to the heart's electrical behavior, right from the chest wall. Alright class, now let's put everything together by reviewing the exact placement for the precordial, chest, leads. This image shows the 6 V leads positioned across the chest. Remember, these leads are crucial because incorrect placement can lead to misinterpretation of the EKG. So let's go over them carefully. V1 goes in the fourth intercostal space, just to the right of the sternum. V2 goes in the fourth intercostal space, to the left of the sternum. V3 is placed midway between V2 and V4. V4 is located at the fifth intercostal space at the midclavicular line. This is one of the most commonly mispositioned, so double check. V5 is placed horizontally level with V4, at the anterior axillary line. V6 is also level with V4 and V5, but goes further out at the mid-axillary line, right under the midpoint of the armpit. Now, on the right side of the slide, you'll see a reminder of the limb lead placement. RA and LA go on the upper arms, and RL and LL on the lower legs or fleshy parts of the limbs, making sure they're evenly placed and consistent on both sides. This layout ensures we get a complete view of the heart's electrical activity, both from the frontal and horizontal planes. So every lead has a purpose, and proper placement is a critical skill you'll use over and over in clinical settings. Let's talk EKG leads, basically the stickers and wires that turn your patient into a live science project. We start with 10 electrodes total. 4 go on the limbs, right arm, right leg, and 6 go across the chest in specific spots. Now, here's the fun part. Those 10 little stickers magically give us 12 total leads. How? The limb electrodes create 6 leads, 3 standard and 3 augmented, and then we have 6 chest leads, labeled V1 through V6. Each lead gives a different camera angle of the heart's electrical activity, so when you put them together, you get the full picture of what's going on inside. And yes, placement matters. If you slap one in the wrong spot, you might think your patient is having a heart attack when they're actually just chilling. Alright class, let's talk EKG paper, because those little red squares? They're not just random graph paper. First off, EKG paper is heat and pressure sensitive, which means it only responds to the stylus on the EKG machine. So no, you can't fill it out with your Bic pen. Now, the horizontal axis, this is your time tracker. Each tiny square left to right equals 0.04 seconds, and 5 of those small squares make one large box, which equals 0.2 seconds. The vertical axis is all about voltage or amplitude, basically, how strong the heart's electrical signal is. Each small box here equals 0.1 millivolts, MV. Standard paper speed, 25 mm per second. You'll usually see this printed at the top or bottom of the strip. This is what keeps rhythm interpretation accurate. Then there's gain, how tall the waves appear. The default is 10 mm per millivolt, so if your machine's calibrated right, a 1 millivolt signal will make a 10 mm tall spike. Bottom line, EKG paper is like the heart's diary, but to read it right, you've got to understand the timing, the voltage, and make sure your journal pages are set up correctly. Let's dive into the ECG waveforms, which are the key to understanding a patient's heart rhythm. Each part of the tracing tells us about different phases of the heart's electrical activity. We start with the P wave. This little bump represents atrial depolarization, which is the electrical signal that causes the atria to contract and push blood into the ventricles. Next is the QRS complex. This sharp spike shows ventricular depolarization, meaning the ventricles are contracting to pump blood out to the lungs and the rest of the body. It's usually the most prominent part of the tracing. Then we have the T wave, which shows ventricular repolarization. This is the recovery phase where the ventricles are resetting electrically so they can contract again. The U wave may or may not be visible. It's believed to represent repolarization of the Purkinje fibers or the bundle of His. Basically, the final cleanup step in the heartbeat process. Now let's talk about the intervals. The PR interval starts at the beginning of the P wave and ends at the start of the Q wave. It measures how long it takes the electrical signal to travel from the atria to the ventricles. The QT interval goes from the start of the Q wave to the end of the T wave. It represents the total time for the ventricles to depolarize and then repolarize. Finally, the ST segment is the flat part between the S wave and the start of the T wave. It reflects the time between ventricular contraction and the beginning of recovery. Any elevation or depression here can indicate serious heart issues like ischemia or myocardial infarction. These waveforms and intervals are what we use to detect arrhythmias, heart blocks, and other cardiac abnormalities, so make sure to get familiar with them. As a medical assistant, your role in EKG interpretation is crucial. Not because you're diagnosing, but because you're responsible for ensuring the tracing is accurate, clean, and usable by the provider. Let's break down 3 terms you need to recognize. First, artifacts. These are abnormal findings on the EKG that don't come from the heart at all. They're usually caused by things like poor electrode placement, loose wires, patient movement, dry gel, or even electrical interference in the room. Your job is to recognize when something doesn't look right and correct it before the provider reads the strip. Next is arrhythmias. This is a general term for any abnormal heart rhythm. It could be something minor like sinus arrhythmia or something more serious like atrial fibrillation. You don't need to interpret the rhythm fully, but you should be familiar enough to spot when something looks abnormal and report it immediately. Finally, we have dysrhythmias, which are usually considered more serious or dangerous arrhythmias. These are irregular rhythms that can potentially lead to life-threatening situations, like ventricular fibrillation or ventricular tachycardia. If you notice this kind of tracing, it's urgent that you alert the provider immediately. So remember, your role is to recognize the difference between a clean tracing and one that needs to be repeated or flagged for review. Quality and attention to detail really matter here. As medical assistants, we are not responsible for diagnosing or officially interpreting an EKG, but it's incredibly helpful to understand what the provider is looking at so we can assist better and recognize when something is clearly abnormal. Here's what's typically assessed in an EKG. Heart rhythm. This tells us if the heart is beating in a regular, coordinated way. The EKG is the best tool for evaluating rhythm abnormalities like atrial fibrillation or bradycardia. Heart rate. The rate can be quickly calculated by counting the number of QRS complexes in a 6-second strip and multiplying by 10. This helps determine if the heart is beating too fast, too slow, or just right. Intervals and segments. The provider will look at the PR interval, QT interval, and the ST segment to determine if there are conduction delays, blocks, or signs of ischemia. You don't have to measure these as a MA, but you should recognize if something looks off, like an elevated ST segment, which could signal a heart attack. Waveform changes. Subtle changes in the P wave, QRS complex, or T wave might indicate a variety of issues, from electrolyte imbalances to myocardial infarction. You won't diagnose, but knowing the basics will help you recognize when a tracing needs immediate attention. So while you're not interpreting it clinically, you are a key part of making sure the provider has clean, accurate data to work with. Ready for the next slide whenever you are, Donnie. Ask ChatGPT. When we're doing EKGs, one of our most important jobs is making sure the tracing is clean and readable. That means understanding and spotting artifacts. These are things that interfere with the EKG recording but aren't coming from the heart. Let's walk through the 4 main types. AC interference. A. this looks like rapid, uniform spikes across the baseline. It's usually caused by electrical interference, like a nearby cell phone, IV pump, or even fluorescent lights. Make sure all electronics are moved away and cords are untangled. Somatic tremor, B. These are uneven, erratic spikes and they're caused by muscle activity. If your patient is cold, anxious, or shivering, this kind of artifact may appear. A warm blanket and calming reassurance can help reduce this. Wandering baseline, C. This is a slow, undulating movement of the baseline and usually happens when electrodes are loose or placed over body hair or oily skin. Always clean the skin and remove excess hair before placing leads. Interrupted baseline, D. This appears as a flat line or sudden breaks in the tracing. It typically means there's a broken or disconnected lead wire. Always check your cables and connections if you see this. Knowing how to identify these artifacts and correct them ensures your provider gets the most accurate reading, and that's crucial for patient safety. This slide shows us what a normal sinus rhythm, or NSR, looks like, and this is what we hope to see on most healthy patients' EKGs. Let's break it down. First, the rhythm originates at the SAW node, which is the heart's natural pacemaker. It's located in the right atrium and it sets the pace for the entire heart. A key thing to look for is that P waves are upright. That tells us the atria are depolarizing correctly. Also, the QRS complex should be narrow, showing that the ventricles are contracting properly. The rhythm must be regular, meaning the time between each P wave and each R wave stays consistent. You don't want any skipped beats or sudden slowdowns. And lastly, the rate should be between 60 and 100 beats per minute. Anything slower is considered bradycardia, and faster is tachycardia. This is the gold standard of what we compare other rhythms against. If students can confidently identify a normal sinus rhythm, they'll have a strong foundation to recognize abnormal ones. Now let's take a look at some abnormal sinus rhythms, which are rhythms that still originate from the SAW node, but have irregularities in rate or pattern. We're going to start with sinus bradycardia. This rhythm still comes from the SAW node, but the heart rate is less than 60 beats per minute. It's commonly seen in well-trained athletes or during sleep. You'll notice on the strip that the QRS complexes are spaced far apart. This helps you visually recognize bradycardia. Next is sinus tachycardia. This also originates from the SAW node, but the heart is beating too fast, over 100 beats per minute. On the EKG strip, you'll see the QRS complexes are closer together than normal. This can happen due to exercise, fever, stress, or certain medical conditions. Finally, we have sinus arrest. This occurs when the SAW node fails to fire for a moment, resulting in a pause in the heart's electrical activity. On the strip, you'll see a sudden flat line or gap between waves where the heart didn't beat. If this pause lasts more than 6 seconds, it's considered clinically significant and might require intervention. These are all important for students to recognize on the CCMA exam. Even if medical assistants don't diagnose, they need to recognize when something doesn't look normal so they can report it right away. Here we've got sinus bradycardia, fancy term for a slow heartbeat. Now, sometimes this is totally normal, especially for athletes whose hearts are so efficient they don't need to beat as often. But in other cases, it could mean the heart's electrical system is dragging its feet. The sinus node, your heart's natural pacemaker, is still in charge, but it's sending signals out at a slower rate than usual. That slower rhythm can cause symptoms like dizziness, fatigue, shortness of breath, or even fainting spells. Treatment depends on the cause and how bad it is. Could be as simple as adjusting medications or lifestyle changes, but in more serious cases, a pacemaker might be needed to keep things on beat. Bottom line, slow isn't always bad, but if it's causing problems, it's time to figure out why and get that rhythm back on track. Alright, let's move into abnormal atrial rhythms. This is where the atria decide to get a little wild with their contractions. First up, atrial flutter. On the EKG strip, it's rocking the classic, sawtooth, baseline. That means instead of normal P waves, you've got rapid, regular flutter waves. The atria are contracting way faster than the ventricles, which creates that sharp, jagged pattern. It often pops up in patients with heart disease or after cardiac surgery. Next, we've got atrial fibrillation, or AFib, and this one's chaos. The atria aren't beating in sync at all, they're just quivering. On the strip, you won't see any clear P waves, and the rhythm is what we call irregularly irregular. The QRS complexes are usually narrow, but they come at random. AFib is super common in older adults and is a big risk factor for stroke. And then, there's asystole, the scariest of them all. This is the flat line. No electrical activity, no pulse, no heartbeat. The patient is unresponsive, and this is a full-on code blue. Immediate CPR and advanced life support are the only moves here. Remember, as CCMAs, we're not diagnosing. Our job is to recognize when something looks life-threatening and get help fast. Atrial fibrillation is one of the most common cardiac arrhythmias you'll encounter. It occurs when there are electrical disturbances in the atria or AV node, which cause the atria to quiver instead of contracting effectively. When you look at the EKG strip here, notice how there are no distinct P waves. That's a key characteristic of AFib. Instead of clear, regular atrial activity, the baseline appears chaotic and irregular. The rhythm is irregularly irregular, meaning both the timing and spacing of QRS complexes are unpredictable. This rhythm can lead to poor blood flow, and patients are often at high risk for blood clots and stroke. That's why identifying AFib and reporting it quickly is so important. Even though medical assistants don't diagnose, we play a vital role in recognition and prompt communication. Make sure students understand, if you ever see an EKG that looks irregular with no clear P waves, think AFib. Alright, time for the scary stuff, abnormal ventricular rhythms. First up, ventricular tachycardia, or VTach. This is when the ventricles are beating way too fast, and it's usually unstable. If you see this on an EKG, don't just stare at it, notify the provider right away. This can quickly turn into something worse. Speaking of worse, meet ventricular fibrillation, or VFib. This is when the heart's electrical activity is completely unorganized. It's basically electrical chaos. There's no QRS complex, which means there's no real heartbeat, and the patient isn't getting any blood flow. This is a full-on emergency. Call for help, notify the provider immediately, and be ready for CPR and defibrillation. These rhythms aren't just off, they're life-threatening, so quick action can be the difference between life and death. This slide explains the 1500 method, a quick and accurate way to calculate heart rate from an EKG strip, but only if the rhythm is regular. That means the spacing between the R waves must be consistent. If the rhythm is irregular, you should not use this method. Here's how it works. First, identify 2 consecutive R waves on the EKG strip. Then count the number of small boxes between those 2 R waves. Finally, divide 1500 by that number. The result gives you the beats per minute, BPM. Why 1500? Because there are 1500 small boxes in 1 minute on a standard EKG, which runs at 25 mm per second. Let's walk through the example. Say there are 15 small boxes between 2 R waves. 1500 divided by 15 gives you a heart rate of 100 BPM. This method is fast, reliable, and great for normal sinus rhythms or any other regular rhythm pattern. It's especially useful when interpreting strips during an EKG lab or exam setting. This method is ideal when dealing with irregular heart rhythms. Unlike the 1500 method, which requires a regular rhythm, this one works even when the rhythm is inconsistent, such as in atrial fibrillation. Here's how you do it. First, identify either the P waves or R waves. Most commonly we use the R waves because they're easier to see. Then, count 30 large boxes on the EKG strip starting from the first R wave. Within those 30 large boxes, count how many R waves you see. Once you have that number, multiply it by 10. That gives you the heart rate in beats per minute. Why does this work? Because 30 large boxes equals 6 seconds of EKG recording, and there are 60 seconds in a minute. So multiplying by 10 scales the number up to a full minute. For example, if you see 7 R waves in that 6-second span, multiply 7 by 10, and you get a heart rate of 70 BPM. This is a quick method used often in clinical settings, especially during emergencies when time is critical. A Holter monitor is a portable EKG device that patients wear over a longer period, anywhere from 24 hours to several weeks. The goal is to catch irregular heart rhythms or abnormalities that may not occur during a short, in-office EKG. These devices are small, about the size of a deck of cards, and are typically worn on a belt or around the neck. Electrodes attached to the patient's chest to monitor heart activity continuously while they go about daily life. This is especially useful for patients who experience occasional symptoms like dizziness, fainting, or palpitations that aren't caught in a brief EKG session. There are now wireless Holter monitors that transmit data in real time, allowing providers to catch dangerous arrhythmias as they happen. These modern versions can even alert providers to significant cardiac events while the patient is still wearing the device. Overall, Holter monitors offer a more complete picture of a patient's heart rhythm over time, which is key in diagnosing intermittent cardiac issues. An exercise EKG, also known as a stress test, is performed to evaluate how well a patient's heart functions under physical stress. It's especially helpful for patients who have had a myocardial infarction or heart surgery, or for those with suspected coronary artery disease. During the test, the patient is connected to an EKG machine and then asked to perform gradual physical activity, typically walking on a treadmill, riding a stationary bike, or using a stair-stepper. The goal is to increase the patient's heart rate while monitoring EKG readings to check for any irregularities that may not show up when the heart is at rest. The medical assistant plays a key role in this test. We're responsible for setting up the equipment, placing the leads, and monitoring the patient's blood pressure before, during, and after the activity. It's important to closely watch for signs of distress, like chest pain, dizziness, or shortness of breath, and to be ready to stop the test if needed. This procedure helps providers assess how much stress the heart can handle and whether further testing or treatment is needed. EKG quiz. What does an EKG measure? A. Blood pressure. B. Electrical activity of the heart. C. Oxygen levels in the blood. D. Heart sounds. What is the normal range for a heart rate as measured on an EKG? A. 40 to 60 beats per minute. B. 60 to 100 beats per minute. C. 100 to 120 beats per minute. D. 120 to 140 beats per minute. What does the P wave represent in an EKG? A. Ventricular depolarization. B. Atrial depolarization. C. Ventricular repolarization. D. Atrial repolarization. Which segment of the EKG represents the period between ventricular depolarization and repolarization? A. P wave. B. QRS complex. C. T wave. D. ST segment. What might an elevated ST segment indicate? A. Normal heart function. B. Myocardial infarction, heart attack. C. Atrial fibrillation. D. Sinus bradycardia. Answers. B. Electrical activity of the heart. B. 60 to 100 beats per minute. B. Atrial depolarization. D. ST segment. B. Myocardial infarction, heart attack.